All right. Well, let's go ahead and get started. We have a really great agenda for you all today. So, welcome again, and thank you for joining us for today's symposium, Emerging Topics in Women's Health, Autoimmune Disease Challenge. This is part of VCU's Health of Women 2024 conference, and I'm Katie Schubert. I'm president and CEO of the Society for Women's Health Research, which is a national nonprofit dedicated to advancing women's health through science, policy, and education while promoting research on sex differences to optimize women's health. And our vision is to make women's health mainstream. For more than 30 years, SWHR has led interdisciplinary groups of researchers, healthcare providers, patient advocates, and policy leaders to address diseases and conditions that disproportionately, differently, or exclusively affect women. And sex and gender influences on autoimmune disorders are undeniable, with women representing more than 80% of the 23.5 million individuals in the United States living with autoimmune diseases. And depending on the source, there's between 80 and 150 conditions identified as autoimmune or immune-mediated. SWHR's work in the autoimmune space has been leveraged to inform disease prevention and treatment and to provide guidance for research, clinical care, and effective policy solutions. For those of you who are active on social media, and we hope that you are, we are live tweeting today's event, and we invite you to join us by using the hashtag SWHRTalksAutoimmune. You can use those on all social media channels. And with that, let me introduce SWHR's Chief Science Officer, Dr. Irene Aninye, who is moderating today's symposium. Irene?
Thank you, Katie, and welcome everyone. Today's symposium will discuss advances in autoimmune disease research and women's health care across the lifespan, with special emphasis on pregnancy and maternal health, caregiving for someone with autoimmune disease, and the menopause transition. Our distinguished panelists will present strategies as to how research, clinical, and policy stakeholders can all work together to address persistent gaps, disparities, and unmet needs for women living with autoimmune diseases. Chronic health conditions and their medical treatments can play significant roles in maternal health. Many women with chronic conditions will encounter challenging conversations surrounding family planning, medication use during pregnancy and lactation, and postpartum recovery and wellness. The safe and appropriate inclusion of pregnant and lactating people in medical research is necessity to providing answers for women and their healthcare providers to make the best informed decisions about their autoimmune disease, maternal health, and the health of their baby. Dr. Stacy Bell is the Executive Vice President for Lupus Therapeutics and a dynamic leader and researcher with more than 25 years of diverse experience in discovery research, drug and device development, scientific strategy, education, and patient advocacy. She has been involved in all phases and functional lines of the preclinical research and clinical development processes. Dr. Bell's work in the autoimmune space spans widely, as she previously served as a chief scientific and medical officer for the National Psoriasis Foundation. Throughout her career, she has been dedicated to optimizing treatment options for unmet needs, improving access to care, fostering partnerships, and taking innovative approaches for program strategies, all underscoring her presentation today that will address the pregnancy challenge and how we can provide better maternal health care for women living with autoimmune diseases. Even for conditions that have similar occurrence among men and women, such as psoriatic arthritis and myasthenia gravis, the burden of disease is arguably greater for women due to gender and cultural influences. Culture and gender influences have psychosocial effects and create expectations of caregiving for children, partners, and parents who may suffer from chronic conditions, including autoimmune diseases. While caregiving can present physical, financial, and emotional challenges, there are benefits and great satisfaction that can come from providing care and support to optimize a loved one's health. Estela Matacarcamo is the president and co-founder of Looms for Lupus, a nonprofit organization that provides lupus, fibromyalgia, and mental health awareness, advocacy, and support to those living with these conditions, as well as their loved ones and caregivers. Estella has worked in healthcare for over 30 years and currently supports private practices with electronic medical records and office workflows to help the practice and patients. In 2011, she co-founded Looms for Lupus when her sister almost lost her life to immune thrombocytopenia and lupus. She is alive today because she advocated for herself. Estella's passion to help others has evolved to empowering and supporting the community as a whole to take control of their overall healthcare. This includes co-facilitating support groups, leading educational symposia, and advocating on local and national levels. Estella will be presenting about the Caregiving Challenge, bringing insight from both her personal and professional experience in the patient advocacy space. Diagnosis and treatment of autoimmune conditions can further be complicated with aging. Midlife, particularly during the menopause transition and after, can have implications for women and their autoimmune health. These conditions may affect and or be affected by the menopause transition. But key issues to consider when managing menopause and autoimmune diseases are your disease onset and your symptoms, your menopause onset, and the impact of menopause on autoimmune conditions, as well as the role of hormone therapy. Dr. Joanne Pinkerton is the Mamie A. Jessup Professor of Obstetrics and Gynecology and the founder and division director of Midlife Health at the University of Virginia. Midlife Health specializes in caring for women 40 and beyond, offering evidence-driven expert care, serving as a site for medical and graduate education, conducting clinical research, and being active within the surrounding community. Dr. Pinkerton is a certified menopause practitioner and the Emeritus Executive Director and past president of the Menopause Society. As a menopause specialist, she is frequently consulted by colleagues about women with complicated autoimmune disorders to evaluate whether menopausal hormone therapy is safe, helpful, or might worsen risks or their underlying autoimmune condition. Dr. Pinkerton has amassed over 200 peer-reviewed publications, invited papers, and book chapters, and has been a PI for over 30 clinical trials, most recently for dual neurokinin receptor antagonist for hot flashes. She will present today about the Menopause Challenge, with a special emphasis on hormone therapy and its impacts on autoimmune disease in midlife and older women. Policy solutions that can properly address unmet needs in autoimmune disease research and care require engagement of policy, science, and patient perspectives. Investment in research requires education and awareness across diverse stakeholders, and innovation paired with human feedback is crucial to developing evidence-based guidelines that can impact and are impacted by insurance coverage. Everyone has a role to play in healthcare policy agendas that advance women's health and promote legislative change in the autoimmune space. Unfortunately, too many potential players are unaware of the opportunities to enhance their bench and bedside work through advocacy efforts. Lindsay Miltenberger is a Chief Advocacy Officer at the Society for Women's Health Research, where she leads SWHR's policy agenda, building relationships with policymakers and stakeholders to advance women's health. Lindsay drives efforts to raise the visibility of and promote the value of health services and systems research through government relations, communications, and advocacy. Among her many areas of focus are building and leading coalitions and partnerships to advance healthcare policy legislation for endometriosis, heart health, and other under-recognized areas of women's health, including autoimmune conditions and diseases. After our 4 presentations, live attendees will have the opportunity to engage in Q&A with the panel to discuss approaches to improve autoimmune disease outcomes for women across the lifespan. And so with that introduction, we will now welcome Dr. Stacy Bell, who will discuss the pregnancy challenge. Thank you for joining us, Dr. Bell.
Thank you very much, Irene. I will share my screen. Okay. Hopefully everyone can see my screen all right. So good morning, good afternoon, everyone. As Irene mentioned, my name is Stacy Bell, and I am fortunate to serve as the Executive Vice President for Lupus Therapeutics. Lupus Therapeutics is the clinical affiliate of the Lupus Research Alliance, which is one of the world's largest funders in lupus research. And I'd like to say, happy Lupus Awareness Month to everyone out there. I spent over 20 years in industry, again, as was mentioned in my introduction, at which time I focused on leading teams in clinical development and in clinical pharmacology. Therefore, I've spent a number of years focusing on clinical trial inclusion and outcomes. Over the last several years, I've really focused on autoimmune and immune-mediated disease, and I've been fortunate to partner with the Society of Women's Health Research on many endeavors. I'm doing so today to address a topic that's near and dear to me, and that is the inclusion of women in clinical trials, particularly at all different stages within their life. So for me, this is very personal, and showing some of these personal pictures, I hope that denotes that. So during my first pregnancy, I had some complications. Reflecting on it now, over 20 years ago, I have many factors that suggest I have some type of autoimmune syndrome of some sort, nothing that's ever been able to be identified. But during my very first trimester of my first pregnancy, I developed idiopathic urticaria, and it basically severe hives that racked my body with waves from head to toe. Finally, when the hives began to become internal, I knew that we were facing a challenge. And the inflammation became a concern for kind of my overall long-term health and that of the baby. And so at that point in time, I was presented with a number of options as far as things that could be done. And with each, I asked about the risks and what knowledge was available about these different ways that, to help me and to help my fetus. And, I was basically told that there just weren't clinical trials or testing to be done, to really define or inform the best approach. So we made a decision, and thankfully, after a week or two, I had some relief from the chronic and rampant inflammation that was occurring. And I went on to have a successful pregnancy. But it really highlighted for me during a time when I was doing a lot of my clinical pharmacology training that there were still so many unanswered questions in regards to women's health, and that the way our clinical trials were being conducted were not really able to address that. So as you'll hear today, a women's health journey really goes throughout life, as a young girl and entering puberty into those young adult years where autoimmune conditions, many of which are very prevalent at that point in time, through pregnancy, which I will touch on today, and then entering later stages of life. And then something I never thought I would say, now being postmenopausal, now thinking about the considerations and how my body's changing. And again, going back to how healthcare is impacted by how clinical trials are conducted, and really where we still have a significant unmet need in this area. So if we think about clinical trial inclusion and you think about our population worldwide, in most cases right now, we're about equally split between men and women. And in some regions of the world where there's actually more women, influencing populational decisions and healthcare. I'm not that old, but back when I started running clinical trials, all clinical trials were called first-in-man studies. I think that was indicative at the time of, there was a low risk tolerance for individuals entering clinical trials. And so because of it, there was a thought that they could go into men and not impact the childbearing potential of women. During my career, I'll say I was very grateful to see that there was an emphasis starting to be placed on these trials called first in human, and there was more of an emphasis placed on the inclusion of women in clinical trials. But really, why weren't women always included? And there's a number of considerations for including women in clinical trials. I think that, there were some very, very vivid examples that I think we all have in mind. And if you trained during the time I did, I think everyone, saw horrific pictures of thalidomide outcomes. And so in 1977, the FDA did issue a guidance that banned most women from participating in clinical trials and clinical studies. And really, I think that was, a reaction that everyone had. I think there were also a lot of considerations regarding the ethical considerations for having women because of offspring and the potential for that. And also they're caring for their children at the time. There's physiological considerations. Obviously, there's hormonal differences. Even from a historical reference standpoint, most of the medical data that was available for comparison was referenced to studies that had been done in males. And so I think that, that really was even an underlying current there. Our world has changed a lot, and I'm very grateful to say that the path that even I had in my career, being the only female, only woman in my chemistry program, has now changed. But at one point in time, women didn't have the right to make some of these choices, and informed consent was something that was really, left very much up to, the male, whether that be in the relationship or in decision making. Thankfully, there's been an evolution of that, but this is still something that has impacted the inclusion of women in clinical trials. We mentioned, or I already mentioned, the childbearing potential and the potential risk of harm to that. In 1993, the FDA did rescind the 1977 guidelines, and they, did encourage women to participate in studies. Although there is still a concern with this, and there is a risk now from consideration from the drug developers about including women. I think the other important thing to note as far as considerations for inclusion of women in research is that women may have different comorbidities, and they may have different disease prevalence. So if you look at the autoimmune disease space, there's, and I'll get to that in just a few minutes, there's a higher prevalence of the presentation of those diseases within women. And so including those women is very important. As I noted, even from my experience while I was pregnant, there has also been an emphasis on the inclusion of pregnant women in clinical trials. And the FDA released a guidance in 2018 on this as draft. There are multiple reasons that we should consider including pregnant women. Women do need safe and effective treatments during pregnancy. I think this is becoming more and more obvious, whether that be to address the challenges that they may be having with pregnancy, but also that they do need to continue treating chronic conditions and be able to treat conditions that come up during pregnancy. I think that the COVID-19 pandemic highlighted that to even a greater extent for pregnant women. I think there's also a challenge as far as failure to establish dosing or dosing regimen in a pregnant woman that may actually compromise the health of not only the woman but the fetus. And I think that the only way to really have a good understanding of that is to have these clinical trials. There's also potential that there's a direct benefit to the woman or the fetus during the trial. And without information, it's really difficult to say that that may be the case. Obviously, the treatment that I had during my pregnancy and the difficulties I had was a benefit to me and my developing baby. But there are several examples of that. And then I think the other thing is really to be able to say for pregnant women and the pregnant population, what is an available treatment for them to maintain their chronic conditions. In this case, particularly, we're focusing on autoimmune disease. It really does become an overall public health issue. So as I mentioned, there is a greater prevalence of women in autoimmune disease. The figure on the right-hand side of the slide really denotes this, and you can see that, in diseases like lupus, it's really a 9-to-1 ratio. Interestingly enough, if you go into clinicaltrials.gov, which again, admittedly denotes later phase studies, but there are currently about 1,100 studies in the phase 2, phase 3 interventional space for clinical trials related to pregnancy. Most of them relate to the pregnancy itself, not necessarily intervention. In regards to autoimmune disease, there were only 55 interventional trials within this context, many of which are being conducted outside the United States. And again, some relate to pregnancy. There are very few that actually address interventions within disease. This is changing. So over the last several years, you'll see, and again, I think the pandemic had a positive influence on that, where it really brought more focus on the medications that individuals were taking, how that would not necessarily just impact their disease state, but also risk of infection and potential comorbidities. So additional challenges, for us to consider today in this discussion. There's also a significant impact on the treatments used for autoimmune disease and those how they relate to the ability to become pregnant and then pregnancy outcomes. Many of these agents routinely have been cytotoxic or may have impacts on the developmental process or again, even on the ability to have a healthy pregnancy. Again, many autoimmune diseases disproportionately and more severely impact women of color. And so when you think about maternal health and that also having more negative impacts in the populations of individuals of color or underserved communities, you have really kind of a double whammy there with the autoimmune disease and then the considerations in that regard. Underserved communities also have difficulties oftentimes accessing healthcare, but also access to trials. Many of those elements also relate to potential trust or stigma in participation in trials. And I think the fear of being in a clinical trial, particularly during pregnancy, is something that is challenging when we're trying to recruit for clinical trials in this regard. The other thing too is that, disease pathophysiology may be related to recurrent pregnancy loss or poor outcomes. This could impact the participants, but it could also impact the trial outcomes. So that increases the potential risk for drug developers, and it definitely is a concern for them. Risks for pregnant women living with autoimmune disease. I won't go into this too much today. We could have a discussion really on each one of these, but it was mentioned about the propensity for pregnancy loss and miscarriage. There is a potential for premature labor and premature rupture of membranes, and higher risk of infection, lower platelets, or just lower blood cell counts overall. And sometimes this is related to specific autoimmune disease. Like in my particular case, I have low white blood cell count. I've had that, and they think it's part of my autoimmune syndrome. That comes into play when you're pregnant and you're trying to balance not only your own health, but the baby's health. Blood clot formation was already mentioned, and then high levels of antiphospholipid antibodies. This occurs in about 50% of those living with lupus, but in and of itself is an autoimmune condition, and this there's been a lot of publications and evaluation looking at this potential syndrome and the impact on pregnancy. Other important considerations for the inclusion of women in clinical trials. There's a lot of other factors. Celebrating Asian and Pacific Islander Awareness Month. You can see I chose an image accordingly. My husband is Hawaiian, and it's something that I've really thought a lot about, because even in the Native Hawaiian healthcare and considerations, there's factors that really are not always considered within the realm and context of clinical trials. So if we think about, again, the inclusion, it goes into genetics, it goes into hormonal factors, the age of the individuals, the impact of estrogen, the developmental stage, as I talked about at the beginning, differences between gender and age, and then factoring in or including, race, other social determinants of health, and actual geography. But the important element of all of this is all of these things also inform the health of all men and women, and across the age ranges. And so again, to highlight the importance of considering these factors. But efforts are increasing, as I mentioned. Both the FDA, Health and Human Services, have released guidelines. Diverse trial and diverse women in clinical trial inclusion campaign has been phenomenal to bring that forward. There's also been specific guidelines under disease conditions that have been set forth. I know when I was in the psoriatic disease community, there's been a lot of emphasis placed on that, inclusion in the guidelines published in the Journal of the American Academy of Dermatology, but also specific papers for that. And then in a lot of other conditions, the Lupus Foundation of America has fantastic resources on their website, as well as efforts being done by the Lupus Research Alliance, the LUCIN Network, the Lupus Clinical Investigator Network, the clinical trial network overseen by Lupus Therapeutics, the organization that I lead, has recently formed a health equity working group. We're not only focusing there on race and ethnicity, but also the inclusion of women. And then bodies that really weigh into the care for rheumatology, such as EULAR and the American College of Rheumatology, have addressed these issues as well. In addition, there's a number of examples of recent studies being published where there's management through autoimmune disease throughout pregnancy, or looking at specific treatments within autoimmune conditions, and hopefully these studies will only increase. So to conclude, I think that there hopefully is evident, while there are a number of considerations for inclusion of women in clinical studies, particularly during pregnancy, it's definitely an important element that researchers and drug developers need to consider. And while there are these concerns from a risk-benefit standpoint, it is critical for the understanding of care for women at all ages. It's imperative to have a diverse group of women, particularly in clinical studies, and particularly those evaluating autoimmune disease, because there is a predominant impact on women, and particularly those women of color. And there are many elements during a woman's lifespan that may impact the disease and treatment outcomes and their participation in clinical trials, but it will inform health for all. So with that, I will end. And thank you all very much for your attention.
Thank you so much, Dr. Bell. Next, we will have Estella Matakakramo, who will discuss the caregiving challenge.
Thank you, Ms. Irene. Let me go ahead and start sharing. Can you see my screen?
Yes.
Perfect. Well, thank you to the Society of Women's Health Research for hosting this pre-conference symposium on emerging topics on women's health. As a caregiver and loved one of someone that lives with an autoimmune disease, I'm honored to share my journey and shed a light on the profound effects that these conditions have not only on women's health, but also and the important part that we have in this conversation as caregivers. I'm here today to share a little bit about my dual role as a sister supporting someone with lupus and an advocate for caregivers. I'll share a little bit about my personal journey as a caregiver or loved one and talk about the different roles that caregivers play when caring for someone with autoimmune diseases. Let's see if I can. So as I mentioned, I am Estela Mata. I'm president and co-founder of Looms for Lupus, a nonprofit organization that supports those living with autoimmune diseases like lupus, overlapping conditions. And we also support family members, loved ones, and caregivers. As an ambassador of hope of Mata advocacy and support, we knew that there was so much more that we needed to do besides just living and talking about specific autoimmune diseases, but also the impact that it has on everyone else. Also a healthcare advocate and a loved one and caregiver. So one of the reasons why I started advocating and I started getting involved with advocacy and support is because my sister Juana was diagnosed and almost lost her life to lupus in 2009. So if you can see on the picture on the right side, you'll see my sister Juana. Juana and I are very close. We're a very tight, close-knit family. But for us, everything changed. Everything changed the minute she was diagnosed with lupus, because not only was lupus going to affect her, it was also affecting her children, her husband, and us as a family. We knew that it wasn't just going to impact her. And we wanted to learn about the condition. We wanted to see how we could help her. And we wanted to know how the treatments were going to impact her and how it was going to impact her life. But we couldn't find a lot of resources. We couldn't find a lot of information. We couldn't find the support that my mom needed, the support that I needed, and the support that my sister needed. So we decided to do it ourselves. We saw the gap and, we took initiative. So you'll see the next picture is Juana, and that is one of our first support groups. And as you can see, she's actually loom knitting. And as we say, we always say this, we're knitting a community of hope. And we knew that living with an autoimmune disease was going to be challenging, but we were not going to let it take over everything. And so we decided to incorporate a little bit of the art therapy and incorporate other modalities that not only the individual living with autoimmune diseases were going to benefit from, but also their loved ones and caregivers. So for Juana, loom knitting was a method to help her ease and the stress and continue to take her mind off the disease and everything that was happening around. And we knew that it wasn't going to be for everyone. So we had incorporated a licensed clinical therapist into our support groups, and they taught not only the loved ones and caregivers on different modalities, but also provided that support. We also knew that that wasn't the only thing we needed to do. We also needed to reach out to the community, to those that still were not diagnosed with these autoimmune diseases, because it does take a long time for a diagnosis, and it also mimics so many other conditions. So we knew that it was very important for us to share this with with our young women in the community, with our children, and with the community as a whole. So you'll see us there sharing information. And if you can see, and just at looking at this picture is really the impact that it has on women. You see there are about 5-to-1 ratio, and that's about the ratio that you'll see more women are impacted than men here. And then finally, you'll see the picture of my sister and I on our first time that we went to advocate not only for loved ones and caregivers, that support that is needed for lupus research, and also for more funding. So for us, again, May is very important, and happy Lupus Awareness Month to everyone. So today we're going to cover not only autoimmune diseases challenges, but we're also going to cover, like I said, the crucial role that caregivers and play, when it comes to caregivers. And also we're going to be covering a couple of effective policy solutions that have been presented and the items that we need to still do in the future. So as we delve into the multifaceted caregiving roles, I'm going to skip over this slide because we heard already about the autoimmune diseases, the impact that it has. And so we're going to go ahead and just skip over and go straight to the caregiving. So the multifaceted world of caregivers will explore the impacts that the caregivers face. And there are many impacts that we face. There's going to be the financial impact. We're going to be talking about the emotional and physical challenges that is faced by both the informal caregivers and the formal caregivers. And when we're talking about the informal caregivers, this basically is people like me, people that by default, the loved ones, the sisters, the husbands, that unofficially become caregivers. And then we have the formal caregivers who provide care and get paid for providing the care that the individual needs. So the financial and direct cost that we're talking about are more of the medical expenses and the home modifications that at times are needed. So many people living with autoimmune diseases, each person is very unique. So there's not two people alike living with lupus. And one of the things is you never know. It's unknown on how it's going to impact the individual. So at times, if the individual is affected, maybe wheel-bound, these extra medical expenses, home modifications that are needed, maybe a ramp for the wheelchair. Those are those extra financial impacts that sometimes are incurred. And when we're talking about the other indirect cost, we're talking about the loss of income. In my sister's case, we are so blessed that she still continues to work. So they were not, or her family was not immediately impacted by that. However, there have been times where she is unable to work, and it has impacted the financial impact. It has had a financial impact in her family. So those are things to consider. Also, the physical strain of caregiving. That's one of the things that for us, I think we don't always think about, if things change, and our roles are always changing. If your loved one has full mobility, is able to and capable of doing everything on their own, then maybe that's the time where you're not going to be as strained. But when that individual, your loved one, has the inability to care for themselves fully, then that's when we have that physical strain of caregiving, and we have to be assisting with lifting and having more hands-on care. And we have to be very, very careful as to not over straining ourselves, and also giving us the grace of taking care of ourselves. So a couple of tips that I have for caregivers, it could be, like I said, ever changing. One day you could just, simply be playing a role as a caregiver by just simply being by their side. But there are other times where you need to take care of yourself. And, just like they say when you're on an airplane, you have to take care of yourself first, get that mask and oxygen to you, and then to be able to help the other person. So we need to make sure that we take care of ourselves before we can take care of others. Here are a couple of tips that I have put together, and hope that, all the caregivers out there take a couple of notes. I know it is difficult to put ourselves first, but we have to do that. So as caregivers play a crucial role in supporting the individuals with autoimmune diseases, we have to, again, focus on the self-care to maintain our well-being while caring for our loved ones. So as we continue to explore these practical tips for the caregivers and the role of support networks to further empower ourselves, let's give ourselves the opportunity to, one, learn about the condition as much as you can. That's the one thing that I wanted to know, is how this condition was going to impact my sister, how it was going to impact her life, and how it was going to impact us as a family. Learning about treatments, learning about the treatments, what the side effects are going to be, how it's going to impact her body. Are there any options? When my sister was diagnosed with lupus, there were no FDA-approved treatments specifically for lupus. So understanding the different types of treatments, learning about the side effects, and how you can help your loved one is also very, very important. Being part of the care team, going to the appointments with your loved one, taking notes, being proactive, and tracking the symptoms, and ensuring that you don't take over the appointment, but also that your loved one feels supported just in case they have like that brain fog. Communication is key, not only with the person that you're caring for, but also with the physicians and the providers. You want to be involved. You want to be part of that care team. And also, like I said, preparing for those doctor visits is very important. So not always are we going to have the opportunities to go to these appointments with our loved ones, but it is very important that we allow ourselves to look at other options. How do we prepare for these appointments? Can we go there physically? Can we send an email to the providers on the top priority items? We only have limited 15 minutes at max with these providers, so it's very important to highlight the main concerns at hand. Lifestyle changes and modifications. Learn about how the disease is going to impact the individual. And again, it's kind of difficult because I know it is very different with everyone, but it's important to kind of prepare for that. If they are going to have mobility issues, do we have the ability to expand or modify that bathroom, or have the funds for those ramps that are needed? And most importantly, I have to say is, again, I can't stress this enough. We have to take care of ourselves, because we cannot pour from an empty cup. Now, there are different types of stress relief options that you can use. You can, if meditation's not for you, there are other mindfulness activities that you can do, taking walks, reading a book, art therapy. There are different ways to take care of our bodies. Eating right, you're being able to rest, sleeping well. These are all things that are going to fuel us to be able to continue to care for our loved ones. And more importantly than anything is, if you need support, know that there is support out there. There are different support networks out there. We have a support group. We provide support for caregivers and loved ones. So I'm just opening it up there. Know that, again, you are not alone in this journey. Now, there is a light at the end of the tunnel. I know a lot of times, we forget about the caregiving portion of it and the support that we need as caregivers. And caregiving is a need, indeed a national priority. So as it really directly impacts the well-being of individuals and families and the community as a whole, and the challenges that are faced by the caregivers, whether we're caring for our children, for the elderly, or those with chronic autoimmune conditions like we're talking about today. The Biden-Harris executive order on caregiving support is an example of something that's already being done. And this Biden-Harris executive order actually was announced in April of 2023, and it acknowledges both the financial, emotional, and the physical challenges faced by caregivers across the lifespan. And what it does is emphasizes the affordability. It emphasizes on respite care and streamlined access. Not just for Medicare members, but it also directly supports the caregivers and the vital roles that they play. So this order directly is benefiting the caregivers who frequently face these financial constraints that we were talking about, the limited resources. It also is prioritizing on respite care and offering relief for the caregivers. And I know at times we don't want to say we need this rest, but it is important to be able to utilize these different benefits. Also, it's going to, or it has been acknowledging the unique challenges that are faced by military families and their caregivers as well. And it provides benefits through dependent care flexible savings accounts. So there is, like I said, light at the end of the tunnel. There are things that are being done right now. However, we know that even though this has been a significant step, there's still much more that we can do to enhance the caregiver support. I think the sessions and symposiums like what we're doing today are going to be something that we will continue to do, setting that priority on educating about autoimmune diseases, about the impact that it has on caregivers and loved ones. That is very, very crucial. So by providing the accurate information about these conditions, we can better understand the conditions that we are supporting our loved ones. Also, telehealth, different options, support options. The telehealth provides convenient ways for us as caregivers to be able to attend these medical appointments by, not being able to always take time off of work. So those are options that I think we need to continue to advocate for. Also advocating for policies that are promote both workplace flexibility are very essential. I know for me, I work full-time. Juana's husband works full-time, and to be able to have that flexibility, sometimes work remote hours or take time off, I think that is something that we need to continue to advocate for. And most importantly, again, advocating for policies that continue to prioritize our mental health resources, because caregiving can take a toll on the individual caring for their loved one. I think it is very important to focus also on different methods and support that we can support the individual when it comes to mental health, counseling service, and also self-care strategies, and most importantly, the support networks. We want everyone to know that they are not alone. And I want to encourage everyone to reach out to us if you need any information, if you want more support. The support groups that we offer are virtual, so you don't have to come in person. So if you need any more information, you can visit our website, follow us on social media. So thank you again for this opportunity to share a little bit about my experience and the caregiver role and the support that we have. Let me see if I can stop sharing.
Awesome. Thank you so much, Estella. This has been very, very helpful in sharing that perspective that is very much needed in this space. Please note that those who are tuned in live can submit questions at any time using the Q&A function, and we will try to address as many as we can during the panel discussion portion of the event. Now, please welcome Dr. Joanne Pinkerton, who will help us to better understand the menopause challenge.
Just to mention that I have been, first of all, thank you very much for inviting me. These conversations are very empowering to listen to and to learn. And so I hope the audience is getting as much as we are that are participating. I have been a site PI for a multi-center clinical trial with Bayer for a new non-hormone treatment. The fees go to UVA. And I really just want to talk today about the impact of autoimmune diseases during the menopause transition. And just a reminder of what happens during menopause. We have hot flushes, night sweats, sleep disturbances, sometimes linked to the hot flushes. You could have change in mood, depression, anxiety. You could have brain fog, difficulty with learning, memory, concentration, weight gain right around the abdomen and the hips. Bone loss happens rapidly. We get changes in lipid profiles, risk of heart disease. And then later on, we can get some of the vaginal issues with dryness, burning, pain with sex, and bladder issues with urgency. So I just kind of wanted to put in context what I deal with every day in terms of menopause. And then the background is that the autoimmune diseases can attack the tissue it's supposed to defend. And sex chromosomes are felt to play an essential role in women who suffer from this, although it's not exactly clear what the role of the sex hormones is. And it is also not clear whether hormone therapy at menopause is helpful, reduces the incidence or severity of different diseases. Because for some, the autoimmune process is going to have increased health risks. And for others, taking hormone therapy has to be carefully weighed against the risk, particularly of thrombosis for things like lupus with antiphospholipid antibodies. And these are the ones that I could find that really intersect with menopause. So it's Turner syndrome, Hashimoto's, premature ovarian insufficiency, muscular sclerosis, Sjogren's syndrome, rheumatoid arthritis, scleroderma, and systemic lupus erythematosus. And my role is often I'm the clinician, the gynecologist, trying to talk about hormones and managing menopause. And working in partnership with neurologists, cardiologists, and rheumatologists. And one of the problems is that the data on hormone therapy is limited. So it's considered safe in women with rheumatoid arthritis or MS and those with premature menopause. And again, remember that, one of the big take homes in the last few years is that as women go into menopause, if they're under age 60 or they're within 10 years of menopause and they're healthy, that hormone therapy is safe, particularly if they have a low cardiovascular or breast cancer risk. We worry about advanced age, and then we worry about underlying risks. And one of those might be lupus or Sjogren's syndrome, where your risk, if you take hormone therapy, might actually be higher than if you don't take it. And that makes it very complicated to make decisions. And not very many people have ever seen anybody with Turner syndrome because it's rare. It's partial or complete loss of an X syndrome. But I recently saw someone. And, it's associated with certain things like short stature, delayed puberty, the ovaries don't work well, and heart disease. But they can have endocrine disorders like diabetes and osteoporosis, and they can have celiac disease and thyroiditis. And I wouldn't have known if I didn't do the research that I should be testing them for both of those. And they have pregnancy complications, but which is hypertension and aortic dissection. But then as they age, there are the multiple organs. And so now we're starting to see Turner syndrome clinics that are showing up that are across the age and not just in pediatrics. Hashimoto thyroiditis, we've all heard about. It's 4 to 10 times more common in women than men, but about 20% have other autoimmune disorders also. It increases the risk of papillary thyroid cancer, but essentially the immune system makes antibodies that attack the thyroid. Initially, you have too much of the hormone, so you're hyper, and then later on you have too little, so you're hypo. But the other issues that come along are this increased risk of lipid abnormalities, heart disease, hypertension, and even something called myxedema, where your body systems slow down so much that it's life-threatening, can cause problems during pregnancy. But in the area of menopause, it's often really complicated because your thyroid abnormalities are fluctuating and your hormones are fluctuating. And oftentimes it's like coming to this constellation of, do we fix the hormones? Do we fix the thyroid? Which one is affecting the other? And so I'm always very happy to have an endocrinologist to work with me when we're dealing with trying to adjust hormones, and always doing transdermal to avoid that interaction with the thyroid medication. POI, premature ovarian insufficiency, means that your ovaries age much earlier than they should. Could be a chromosomal, could be autoimmune, could be a cancer treatment, but autoimmunity could be anywhere from 40 to 30% of the cases. And it's usually not just associated with the ovary, it can be associated with disease of the adrenal, the thyroid, and the pancreas. And we don't have good antibody testing. There's really no good anti-ovarian antibodies. So we end up doing adrenal antibodies and thyroid antibodies to say, does this look like you're having more of a systemic autoimmune process? And then there's a condition called autoimmune polyglandular syndrome, which is sort of everything. And one of my patients started with Hashimoto's, came to me because she had early menopause in her 40s, developed diabetes, was on an insulin pump. Then she developed adrenal antibodies, which is called Addison's disease. And now, I mean, she's made it all the way to her 80s because she has a lot of people taking care of her. She's got heart disease, AFib, an insulin pump, and osteoporosis. So just this polyglandular, luckily rare. She's my only patient with it. And just a comment about people who go through an early menopause for any reason, whether it's surgical or autoimmune. And what we have found is that hormone therapy, if you don't have a contraindication, should be taken until the average age of menopause, because not only does it help hot flushes and vaginal changes, but it prevents osteoporosis and fractures. It decreases the risk of cardiovascular disease and overall mortality, which has been seen in these observational studies. And so if you're straightforward, it's pretty easy. I'm going to say, let's take this until the average age of menopause. It is not a contraceptive. So women who need contraception and it is truly autoimmune, we will frequently put you on birth control pills to give you both hormone therapy as well as the contraception that you need, because early menopause is the one time when your ovaries might kick back in and you might get pregnant. So 40 years old, develops POI, is dealing with all of her issues with that, goes on and off birth control pills, and all of a sudden comes in, hasn't had a period, feels miserable. And I look at her and she is actually 7 months pregnant, and she was an endocrinologist, just never thought that POI is the one time we have to worry about pregnancy. Muscular sclerosis is where these attacks hit their scar tissue, and they can hit the brain, the spinal cord, or the optic nerve. We think it's autoimmune, although we don't have antigens. And because it is associated with menopause, and women who have this early menopause are more likely to get progressive MS. And both birth control pills and estriol, which is E3 made when you're pregnant, show a modest effect on the inflammatory activity, maybe a neuroprotective effect. So many of my patients with MS do want to go on hormones for potential benefits, and we at least think it's safe, but we don't know about the long-term effects on neuroprotection. Rheumatoid arthritis, you have this increase in inflammation, and rheumatoid arthritis really has these inflammatory mediators. And we think that the decrease in estrogen plays a role in this. Early oral contraceptives helps protect against it, maybe early menopausal hormone therapy, but interestingly, late menopausal hormone therapy can actually exacerbate it, somehow making the inflammation worse. And then we worry about osteoporosis because that's rheumatoid arthritis, and its medications have a risk for osteoporosis, which of course is worsened when your estrogen levels decline. Sjogren's syndrome, 2 million people in the United States, more than 90% are female, assigned at birth. And this is where the immune system actually damages the parts of the body that produces and controls moisture in the body. So it could be eyes, mouth, vagina, GI tract. can be associated with other medical illnesses, but systemic hormone therapy may increase the risk, so we try to avoid it. But very importantly, we can use vaginal estrogen, so you're not limited to just lubricants and moisturizers, but we try to avoid systemic hormone therapy. It certainly doesn't fix it, and it might worsen it. Scleroderma is another one that gets worse with menopause. This is a buildup of the collagen in the body tissues that involve the skin. And studies have shown that with menopause, there is more thickening of that skin. And also, you might be more likely to get a rare but serious complication called pulmonary arterial hypertension. And so estrogen could worsen the disease through localized inflammation. It's one of those ones where we would avoid estrogen unless we feel like it's medically indicated. And then the hardest one is systemic lupus. And in this one, we really worry about people who have an active antiphospholipid syndrome and the antibody. The higher your lifetime estrogen, the more the risk. So hysterectomized women have been shown in studies to have less risk of getting the anti-double string DNA antibodies with age-matched controls. And there's fewer flares if you have ovarian failure. However, when a woman comes in, you have to think, what's my risk? So what's the disease activity? Do they have the antibody? What happened during pregnancy is going to help you think about what might happen with hormones. Did they have vascular or pregnancy issues? Worried about thrombosis? And then whether or not they're going to have longer term vascular issues like hypertension. And menopausal hormone therapy can be associated with a small increase in flares. So both hormonal contraception and menopausal hormone therapy are controversial. We will sometimes consider them if the disease is really inactive and they don't have the antibody. But if the antibody's positive, then it's really difficult. So here's my patient. I just saw her last week. She came in, she had a preterm birth with loss of a child at 26 weeks. 1 week later, she had a stroke with residual weakness. She came in to see me because she had severe symptoms, hot flushes, 7 to 10 a day, sweating, sleep disturbance. She was miserable, not functioning, couldn't work. We tried low-dose antidepressants, low-dose different types. We tried gabapentin, oxybutynin, which is usually used for overactive bladder. We tried progesterone by itself, or it gave her flu-like symptoms. There's no data on these new neurokinin receptor antagonists. They've only been tested in healthy women. She met with cardiology, she met with hematology. They said, we're going to continue you on an anticoagulant. So after a lot of discussion, we put her on a very low dose estrogen patch. I talked to her last week and she is like, thank you, thank you, thank you. I can sleep, I can function again, but I can't tell her what her actual risk is. So what I want you to take away from all this, I know I threw a lot of diseases and information at you. Number one, women with autoimmune disorders may be worsened after menopause when the estrogen levels decline, and fluctuating levels can make it much more difficult to know what's going on during perimenopause and with the autoimmune disorder. You have to evaluate whether hormone therapy might worsen your risk or what your underlying risks are. But remember that we do have lower doses. We have transdermal that avoids the liver and is bioidentical. We have bioidentical progesterone. And I partner with rheumatology, cardiology, hematology, neurology, trying to navigate some of these complicated cases. If it's early menopause, I'm really going to want to give hormones to at least the average age of 52 if I can. And then remember that we do have options for women who can't take hormones that work for most women. They didn't for that last one, but low-dose antidepressants, one of which is FDA approved, gabapentin, oxybutynin, those are used off-label, and then the new neurokinin receptor antagonist. One is at the FDA, decreases frequency and severity of hot flushes. And there is one that's on the way that has the potential for also helping sleep. Gaps in research, oh my gosh, so much. What happens? How do we help people with early menopause, with POI who want to be pregnant? Can we restore the ovarian function if we do some type of immunosuppressive treatment? if you have MS and we give you hormones, are we helping your brain or hurting your brain? If you have Sjogren's and we could target your B cells, could we improve that for you? And really, what is the influence of these sex hormones and some of the newer compounds? Like there's a new E4 that's in treatment, or there's an estrogen that can be combined with outer progestogen. And then in this laboratory, this XIST gene, which was tested in male mice, back to your clinical studies, didn't cause an immune reaction. So maybe there'll be some new pathways of things that can come forward. So I want to close just to say that perimenopause is really tough because it's fluctuating, and you want to see people who are specialists. And then menopause and the decision about hormone therapy can be very complicated. And even this is my life, this is what I do, and I don't always know the answers. So I love this panel. Thank you for inviting me to be a part of it. With that, I will stop sharing if I can.
Thank you so much, Dr. Pinkerton. Our final panelist and presenter is Lindsay Miltenberger, who will lead us in a conversation about policy solutions. Welcome, Lindsay.
Thank you so much. And thank you all for being here today. And I'd like to thank the other panelists. Really, really fantastic presentations. My presentation today really comes from a lens of believing that researchers and clinicians and patients and caregivers are some of those best suited to raise awareness about gaps and unmet needs in research and clinical care and in practice. And so through what I share with you here today, I hope that you will leave with a better understanding of the myriad ways that you can participate in the policymaking process, and perhaps even be inspired to follow legislation or opportunities that you might not have considered previously. So I'll start really broad, talking about science's role in policy, and then I'll get more granular, eventually ending with some specific opportunities for you to engage. So next slide, please. So in 2002, the Institute of Medicine published a report on the future of the public's health in the 21st century. And the charge of that report was to create a framework for how to assure population health. And within that report, this IOM committee said that the mission of public health is ultimately to fulfill society's interest in assuring conditions in which people can be healthy. And so notably within that report, they assigned the government with three core functions within public health practice, and those are listed here. They were assessing health status and health needs, ensuring that necessary services are being provided, and policy development. And it's really no surprise why the IOM committee designated policy development as a core government function for public health, because each of the 10 great public health achievements of the 20th century, as identified by the U.S. Centers for Disease Control and Prevention, has been influenced by policy change. So these include things like vaccinations, to the recognition of tobacco use as a health hazard, and the use and value of anti-smoking campaigns, to preventing initiation of tobacco use. Next slide. So there's no doubt that there are challenges when it comes to today's political environment, but scientists and clinicians do have a really integral role to play in the policymaking process, given the work that you do and the vantage point that you hold. So you can help lawmakers understand what's going on in your field at any given time and where the state of the science or clinical practice is. And then importantly, you can also provide options to policymakers about different courses they pursue and what outcomes could be if they proceed with any of those options. And especially today, when the current political climate is one where people are often seeking out data that reinforces their belief, even just coming to policymakers with options can be incredibly, incredibly valuable. So I recognize that I'm saying that people should engage in the policymaking process. That's one thing, but it's another thing to actually figure out how you enter in that process in a way that feels right and authentic to you in the work that you do and the perspectives that you have. I think that, so often whenever we think about science policy, we think about, just going up to the Hill and speaking to lawmakers directly, but there are so many other ways that you can have an impact. And so this slide outlines some of the ways that individuals may choose to engage in that process. And I won't read all of them here, but there is the classic direct communication with policymakers. Those may be meetings in Washington, D.C., or when a lawmaker comes home, it may be attending town halls, making a phone call to your lawmaker's office, sending an email, engaging on social media somehow. But there are other ways that you can be engaged as well. Especially in the autoimmune disease and condition space, there are so many organizations that are actively involved and doing really important advocacy and outreach to lawmakers that you could join and become part of. So groups like the Autoimmune Association or the Arthritis Foundation are great places to go to stay tapped in and stay up to date on what's going on in federal policy at any given time. And they will also provide forums for you, create action alerts where you can easily write your member of Congress about a given issue that's affecting the population at any given time. There's also regulatory engagement. So when federal agencies release notices of proposed rulemaking, requests for information, they'll solicit input on things like their strategic plans that the public have the opportunity to weigh in on. And so making sure that you're staying up to date with some of the opportunities that exist within those spaces or following the agencies and entities that you care most about, you could find opportunities there that feel really right and authentic to engage. And then there's also independent organizations evaluations. So here I'm thinking about some of the organizations that engage in the value assessment framework conversation. So a well-known entity in this space is the Institute for Clinical and Economic Review, or ICER, which provides independent evaluations on the value of medical tests and treatments and delivery systems. So that, again, that might not be an area that's regularly thought of, but it's important because sometimes the assessments from entities like this are used to inform treatment decisions, or they can be used to make coverage and reimbursement decisions. So different stakeholders can weigh in at several points throughout those processes to make sure that what matters most to patients and caregivers is being reflected in those final documents, or to make sure that considerations like sex and gender are considered, or when thinking about the variation in response to different treatments, acknowledging the full spectrum of treatment options that are available to a patient with a given medical condition. That's a great way to engage. I've also identified some other outlets here that might serve a good purpose to get in front of policymakers. So this could be attending science conferences where policymakers are going to be in attendance. It could be writing an op-ed to your local or state paper or publication. Again, often lawmakers' offices tend to read state-based or local publications, even over some of the federal national outlets. Writing policy briefs on different subjects, publishing in open access or scientific publications, and making sure that those get in front of lawmakers. And then for those of you particularly with universities or entities with government relations departments, making sure you're really tapping in and utilizing the people that work in those offices, because they could also provide ideas about ways that you might be able to engage given the work that you're doing, or just flagging opportunities that might become available given your area of expertise or your experience. Next slide, please. So using SWHR's autoimmune disease policy work as a case study, we can get a sense of how we might be able to engage in a policymaking process. So to give a little bit of context into SWHR's work in this space, a few years ago, we convened an interdisciplinary working group of researchers and clinicians and patient advocates and policy experts to come together and think about what are the real needs and opportunities in policy when it comes to autoimmune diseases and conditions. There were several different components of that program, including the release of policy briefs and webinars, but that work all culminated in the release of an overarching policy agenda. And that agenda spotlighted areas that kind of rose to the top during our roundtable conversation as areas of greatest need and what people saw as the greatest opportunity when it came to autoimmune disease policy, which we broke out into these 4 buckets that you see here. So it was research opportunities, education, awareness, and advocacy, clinical care needs, and coverage and access. And so the things that you see here were things that working group members identified given their work in these spaces. So under research, it was things like increasing federal research efforts, and we get more granular into the policy agenda. There were some areas specifically that working group members flagged as areas of need. Meaningfully improving diversity within clinical trials, making sure that diverse populations are reflected within autoimmune specific clinical trials. Under education, awareness, and advocacy, as Stella mentioned this during her presentation a moment ago, but improving education and awareness surrounding these diseases and conditions. Under clinical care needs, improving electronic health record interoperability, expanding clinical education, and then under coverage and access, it was things like modifying utilization management policies or incentivizing physician practice in rheumatology. So the goal of this policy agenda was to really serve as a roadmap for policymakers to understand things they could do that would meaningfully improve outcomes for women with autoimmune diseases and conditions over the lifespan. Next slide, please. So we've thought about the gaps. Let's think about the landscape in which we're operating. So as you think about entering into the policymaking process, it's important to remember all the different entities that touch a given issue area. So within autoimmune diseases and conditions, we certainly think of the federal research and public health entities that are serving these populations, but it's also groups like the Food and Drug Administration, which regulate the approval and safety of drugs and biologics and medical devices, and the U.S. Department of Health and Human Services, which develops resources and conducts educational campaigns on a range of health topics. So there are a lot of players that are active in this space. What I have highlighted here is one of the policy briefs that SWHR put together, highlighting how federal agencies are currently supporting women with autoimmune diseases and conditions across the lifespan. Next slide. So we know the gaps, we know the players, and now let's look at some specifics. So these are some specific legislative opportunities and ways that people can engage in the autoimmune space in this particular Congress. So general autoimmune disease education is one. You're going to hear this as kind of a common theme throughout some of these opportunities, but it's really important just to make sure that lawmakers are aware of some of the issues that are facing different populations of individuals living with certain autoimmune diseases and conditions, especially for some of those rare diseases and conditions that may not be as common. It's helpful to create that connection so lawmakers kind of know what to be on the lookout for, or if there is legislation or an opportunity, them having that background, they may be more inclined to be involved in the future. The budget and appropriations process, making sure that federal research agencies have the funding that they need to be able to fulfill and carry out their missions, is a great way to be involved. And then I have a few specific pieces of legislation here. I won't walk through them all, but I'm happy to answer any questions either during the Q&A or you can always send me an email, but I'll highlight a couple of them. So the Advancing Safe Medications for Moms and Babies Act is actually a piece of legislation that a coalition that SWHR administers has been involved with. And this goes to Dr. Bell's presentation earlier, the legislation seeks to implement the recommendations of the Task Force on Research Specific to Pregnant Women and Lactating Women, which is a task force that was established as part of 21st Century Cures. But it really seeks to change the culture around the inclusion of pregnant and lactating populations in research. Really, instead of thinking about it, how do we protect women from research? It's how do we protect women through research? And so there were a series of 15 recommendations that the task force made to the Secretary of the Department of Health and Human Services. And it was really to increase the representation of these populations in research. And so while we have made some progress, there are a few recommendations that are still outstanding. And so this piece of legislation seeks to implement some of those recommendations into policy. So that's one place that people could engage. Clinical trial diversity legislation. There's currently one that is active in the 118th Congress called the NIH Clinical Trial Diversity Act. That legislation sets includes a set of requirements to increase diversity of clinical trial participants. And it includes things like goals for recruiting and retaining trial participants and implementing less burdensome clinical trial follow-up requirements. There's also the Help Co-Pays Act that's been introduced this Congress. A lot of autoimmune organizations have been actively advocating for the passage of this legislation, but it would require that health plans count copay assistance toward a beneficiary's deductible and out-of-pocket maximum. So it's prohibiting the use of copay accumulator adjusters. There's also a Connecting Caregivers to Medicare Act. That bill aims to improve coordination between caregivers and Medicare beneficiaries to make it easier for caregivers to access really pertinent health information about the people for whom they're caring. So those are examples of some of the pieces of legislation that have been introduced this Congress that could make a difference for people living with autoimmune diseases and conditions. You also heard Estella in her presentation reference legislation that supports mental health and legislation that supports telehealth. Those are pieces that may not immediately come to mind as something associated with autoimmune diseases and conditions, but they can have a direct impact on those individuals, whether on health outcomes or quality of life outcomes. So those are just some of the things to think about. Next slide. And, here I just included a quick case study. I know we're quickly running out of time, so maybe I'll fast forward this, but if you look at the Office of Autoimmune Disease Research, this is a success story from how advocacy can have an impact and lead to advances in these areas. So due to advocacy of organizations over several years, the Congress ended up requesting that in some congressional language that the national academies develop a report on autoimmune diseases, which ended up happening. That National Academies Committee ultimately recommended, it concluded that NIH was doing extraordinary work in this space, but that its potential to really take advantage of the work that different institutes and centers had was there was like an absence of an NIH-wide strategic plan and of coordination. And so one of the recommendations from that report was to develop an Office of Autoimmune Disease Research, which ended up coming to fruition in fiscal year 2023 spending legislation. So this all goes back. It takes a while, but it does have an impact. Next slide. And then these are some regulatory opportunities, so ways to engage with federal agencies. Again, education, I've listed here. The Office of Management and Budget, we've heard from directly, really likes to hear from stakeholders about programs they're funding that you all believe are working at any given time. So taking them success stories and showing how these programs are making a real difference in the lives of people across the country is really meaningful to them and incentivizes them to continue to try to fund these programs through the president's budget request and other things. So that's a really great opportunity for education. I mentioned public comment periods earlier, but monitoring federal agencies, opportunities, requests for information to provide input on strategic plans and things like that. The NIH-wide strategic plan for autoimmune disease research closed a few months ago. That came out of the Office of Autoimmune Disease Research. So keeping an eye out for things like that. And then hearings and convenings. Last fall, the Centers for Medicare and Medicaid Services hosted a series of 10 listening sessions on the 10 drugs that were set to be involved in Medicare negotiations between Part D and pharmaceutical companies as part of the Inflation Reduction Act. And so that was an opportunity for patients and beneficiaries and consumers to share input relevant to the drugs selected for the first round of negotiations. So keeping an eye out for opportunities like that is also a great way to engage. Next slide. And then I've kind of already touched on this, and knowing the time, I'll go ahead and skip the value assessment next slide. And then I just had to make a quick plug for our Coalition to Advance Maternal Therapeutics. I referenced it earlier when we were talking about the Advancing Safe Medications for Moms and Babies Act. But again, this group just advocates for the increased inclusion of pregnant and lactating populations within clinical trials. So we would love to have additional autoimmune disease and condition focused organizations involved. But with that, again, recognizing we're coming up on time, I'll go ahead and pause and turn it back over to Dr. Aninye.
Thank you so much for everyone. And I invite the entire panel to turn their cameras on for a brief Q&A. We have about 5 minutes that we can dive in, but I got some questions to just go right in. And we know that there's so much diversity amongst women, and there's so much diversity amongst autoimmune diseases and the experience that women have in women's health and how their body responds to various medications. How often, Stacy, we'll start with you. How often do you come across trials that consider subpopulations of women, for example, Asian or Middle Eastern or even Latina groups that aren't just you lumping the whole, but might have a little bit more granularity? And how can researchers do a better job addressing heterogeneity among women?
Yeah, thank you for the questions. I think that there's definitely a concerted effort now, and there is more activity ongoing. I mean, some of that was prompted, as we're talking about policy, by the FDA, releasing guidance and really a mandate now to drug developers that there needs to be more diversity in their clinical trials. I think importantly, though, organizations, whether they be individuals developing new therapies or whether they be patient engagement organizations and advocacy organizations like many of ours, there's a recognition that if the trials are not diverse and we're not including those impacted by the disease, we're not going to have outcomes that are going to be beneficial for the whole community. And so there's been a lot of work on the advocacy front too, ensuring that those individuals are included in trials. As far as ways that can occur, I think that that's the $1 million question that we're all working on, right? But I think that there's been a number of efforts now ongoing. I can speak to some of the efforts we have at the Lupus Research Alliance. We have a program called Project Change, where we're actually going out into communities and really trying to meet people where they are, whether that be in community centers or faith-based centers, and really trying to, have them not only have access to clinical trials, but have an understanding and have the information for them personally or for their families and their caregivers, as Estella talked about, or even, having a level of trust so that they're willing to ask questions and willing to be involved. I think it's also listening. You can say we're going to make an effort to have all these individuals included in clinical trials, but if you're not hearing their lived experience with a particular disease or their circumstances to be, participating, a number of conversations I have right now with our biopharmaceutical sponsors relate to clinical trial design to enable the inclusion. So if you're in certain communities where individuals have hourly employment, how can they do an 8-hour clinical trial visit? And so it really goes back to not only saying, yes, we're going to include, but thinking about the clinical trial design and ways that you can enable and educate individuals to have, the support and the access. The final thing that I'll say too, that I think is extremely important, is having individuals that look like we do. Having women in research happens because there's other women that have come before us that have helped lift us up and build us up. And the same applies for diversity in clinical study participation. If you are going in to see a provider that's maybe offering a clinical trial and you can't resonate with that individual, they may not look like you look, or they may not be talking to you about the things that matter to you and that you're concerned with, there's going to be less likelihood to participate. So it's really focusing holistically, in my opinion, on not only those individuals that may be coming in, but the individuals that are participating and how they're sharing their experience, and then those individuals that are conducting the research and providing the care, and to really ensure that the process is inclusive.
And actually, I thank you for that. And I think this kind of applies in all spectrums. So we're going to try to pivot this question and ask you, Joanne, is there a push for this approach in menopause research? And I know SWAN that you mentioned and other studies show differences in menopause symptom severity across different groups. But and we see this autoimmune, but that intersection, are you aware of, or like what would you like to speak to that?
It's so we have learned that women have different experiences, different trajectories. It turns out that if the average age of hot flushes is 7 years, Asian women might have them for 5 years, African Americans 7 to 10, and they can start more severe and last longer. So it makes sense that if something as simple as hot flushes is that diverse, then there's going to be other issues, within the autoimmune world in terms of how people are going through perimenopause and menopause. And I do think that if we can't address the issues that are culture specific and how people want them addressed, it's a big issue. And what we know is that women have more antibodies than men in general, but is that different based on different ethnicities? We don't know that. We know that 2X chromosomes, does give you more chance for abnormalities. But what is going on? Why did women in general do better with COVID than men? Was that something that could have been ethnically different also? And then also, what happens in the brain? We're worried about brain inflammation occurring with some of these diseases and whether estrogen helps or hurts that. And that may be very different depending on the different ethnicities and races that are there. And I want to just make one other comment. You said about the interoperability of the epic record or the electronic record. And when you have somebody who's complex and they're in different cities or seeing different specialists, you can't put them all together and say, what's your concern? What do you need to know? What are you worried about this particular patient? Or message everybody and say, you say yes and you say no, I got to make a decision. So I think that it's diversity, but it's also how we come together for an individual woman to do the very best thing. And menopause just makes it more complicated.
And Lindsay, to that, kind of picking up on that, how do you see these differences reflected in accessing care for autoimmune diseases throughout the lifespan, or and how can it better be reflected in policy? Is it reflected in policy, from that standpoint?
I think there's a lot we can do in policy to make sure that these needs are met. I think it's been great to see some of the introductions of pieces of legislation trying to improve diversity within clinical trials. So I mentioned the NIH Clinical Trial Diversity Act, but there were others last Congress, like the Diverse Trials Act. Seeing things like that, the Advancing Safe Medications for Moms and Babies Act, all of those steps signal progress, but we really need champions to, carry us forward and push those bills across the finish line. And we need those efforts to importantly be bipartisan, especially given the current political climate. So I think, we're continuing on the right path, but there's still a lot that we can do.
And I'll round out with you, Estella. Can you talk about how culture affects caregiving and what we should be thinking about when it comes to this space?
I think culture does play a huge role. Like for us, we take care of each other. So we assume that role automatically, taking care of my sister. We're also taking right now, care of our mom. So it's like, and taking care of our children. So culture does play a huge role in participating, whether it comes to treatments, caring for our loved one, or even clinical trial participation. We look to get the ideas, suggestions, and recommendations from our parents, but we also need to include our little ones that perhaps can be in these roles when they're taking care of us or when they're taking care of our elders. So I think culture does play a huge role. So I think including everyone and including more awareness and is really, really important.
Thank you so much. As you can see, just from that one perspective, there's the policy, there's the caregiving, there's the trials, there's the healthcare, there's the research, that everyone is really taking a village to address the holistic needs of women throughout the lifespan when it comes to autoimmune diseases. And so thank you very, very much, everyone, for being on this panel, for presenting and sharing your insights and your time with us today. We also thank Virginia Commonwealth University for their support of this Emerging Topics in Women's Health Symposium. And SWHR would also like to thank Johnson & Johnson for their support of our autoimmune diseases program. SWHR will continue the conversation, hashtag SWHR Talks Autoimmune, in our work to promote research to better understand, diagnose, and treat autoimmune diseases in women, lupus, and menopause. Our two of the focus areas that are in our Women's Health Equity Initiative. And this roadmap features U.S. data and disproportionate impact of certain life stages and women's health conditions based on race and ethnicity, geography, age, and role as a caregiver. So we have our Women's Health Equity Initiative. We also have a policy agendas and patient toolkits and clinician education materials for alopecia areata, atopic dermatitis, lupus, psoriatic arthritis, and other autoimmune diseases that disproportionately affect women and women's health. You can find all of these resources on our website, www.swhr.org. Connect with us there as well as on social media to register for future events, download women's health resources, and sign up for our newsletter. We will send out an email with a recording of today's webinar to all registrants, as well as post the recording on the event's webpage for future viewing. So please be on the lookout for that and feel free to share with others as we continue this very important conversation. #SWHR Talks Autoimmune. Thank you for joining us today.